On the day of surgery, the patients will come into the A wing, the second floor, to the day surgery area. Once they arrive at the A2 Welcome Center, they will be brought into a little cubicle area. They will change into a nightgown. They will have their information they did in pre-admission testing reviewed. They will have blood work. They'll do their vital signs. They will have an interview with the anesthesia team, and their physician will come by to see if there's any further questions that they have, and they will sign their operating room consents and anesthesia and blood consents at that time.
We do try to do regional anesthesia, which involves not putting a tube down your throat. That way you have a little better control over pain afterwards, and studies do show that it's a little safer to do regional rather than general. That will be discussed between you and the anesthesiologist for anesthesia to prepare.
While the patient is in surgery, the family is asked to wait in one of the waiting areas. They will pick up a beeper, and this beeper will work while they are in the hospital. When the beeper goes off, they go back to the waiting area if they're not already there, and at that time, the surgeon will either come to the desk or he will pick up the phone and talk to the family about their loved one.
A hip replacement surgery will take somewhere between 1 and 2 hours in the routine case, and sometimes if it's a very complicated case, it may take a little while longer, but generally within 1 to 2 hours, someone is done and on the way to the recovery room.
Day of surgery, patients are expected to have the operation in the morning, get to their room early afternoon, and try to do first physical therapy session.
After the patient has surgery, they will stay on the A3 unit. The unit has an orthopedic, bariatric, and surgical services focus.
Patients will stay on A3 and be taken care of by a team of experienced RNs and patient care technicians.
After surgery, when the patient arrives on the unit, they will be greeted by the staff, oriented to the room, and they'll be introduced to the communication whiteboard that we use.
The communication board is on the wall at the foot of your bed. We use them as a communication tool for the patient. You will find your nurses, your techs, your doctor.
We also have a pain scale on that board, and it will help you, the patient. If you can't give a number, there are faces correlating with the number. It'll help us to keep you more comfortable. We also write down the last time you received pain medication, and there's an area of special request that if you have a nickname or special food that you like for us to make sure you have every day, we put that on the board. Also on the board is your anticipated day of discharge, any lab work, any plans for that day, who your physical therapist is. It is very concise as to all the things that the patient and the patient's family might like to know while they're in the hospital.
On A3, we round with the patients frequently. We call that purposeful rounding. And during this time, we will check on your pain and your position and if there's any other needs that we could do for you while we're in the room. While in the hospital here on A3, we do a patient-nurse fall agreement, which we would have the patient sign once they got to the floor, and that would just help explain to them why we feel that they need to call for help, and they would use their call bell.
With your total hip replacement surgery, you want to make sure that getting out of bed, you're maintaining your hip precautions that the doctor has set forth for you. What you want to do is, going from a laying position, you want to slide your operated leg to the edge of the bed, then your non-operated leg. You want to then scoot your hips around to the side in order to come to fully upright position.
The days following surgery on the unit, the nurse will work very closely with the patient and help manage pain, and they will also be learning how to ambulate with their new joint with physical therapy as well.
Most of our patients are seen for physical therapy the day of surgery, most likely late afternoon, depending on what time the surgery is. The patient's goals during physical therapy vary between patient to patient, but most of the time the patients want to become independent so they can return home.
A person's goals for occupational therapy vary based on the level of assist they will have at home following their surgery. If someone is going home alone, they need to be independent with things like dressing and bathing with the necessary equipment, be able to toilet themselves, and be able to safely maneuver around with the walker. If a person is going home with assist from family, it may not be necessary to be completely independent, just at a level in which the family is able to manage their care. Following hip replacement surgery, you're placed on total hip precautions, which mean that you're not allowed to bend past 90 degrees at the hip. Therefore, doing things like lower body bathing, lower body dressing are things that you are unable to do without some assistance. So there are a variety of reaching devices available to help you do these tasks. The first one is a reacher. It's used to put on pants, undergarments, can also be used to hold a shoe in place where you slip your foot in. It's also a device that's utilized to pick up items off the floor that you may have dropped or to retrieve items off of low surfaces. The second device is a sock aid. It's just utilized to put your socks on. The third device is a long-handled shoehorn. It's 24 inches in length, so much longer than your typical shoehorn. And if you have trouble putting your shoes on prior to surgery, you may need this device following, just to assist you with getting your sneakers on or whatever footwear you decide to use. And the last device is a long-handled bath sponge, and it's just used to reach your lower legs below your knees, as those are areas that you're unable to reach while maintaining your hip precautions. Large equipment-wise, after your hip surgery, you're not allowed to go down onto a low standard toilet. So a toilet riser or a commode style device is needed to make your height of your toilet adequate so that you maintain your hip precautions. The other thing that you may or may not need is a shower seat. We talk to you about that piece of equipment on an individual basis when you come into the hospital.
In order for a patient to return home after surgery, they have to be walking at least short household distances. This can be either used with a walker, crutches, or a cane. They also have to be able to get in and out of bed by themselves, and if needed, be able to go up and down the stairs depending on their home situation.
Hospital stay has been going down in length. Historically, we used to keep people for a long time. Typical length of stay nowadays will be anywhere from 1 to 3 days. At 3 days, we will discuss with the patient about going to rehab. Most people are able to go home.
The main criteria for going home is that your pain can be controlled with medications you can have at home. You need to achieve certain mobility goals. You should be able to get in and out of bed on your own, walk 100 feet or so, generally with a walker. You want to be able to go up and down a few stairs, get in and out of a motor vehicle. The goal is to have you so that you could take care of yourself in your own home with minimal assistance. Pain management after surgery for me begins in the operating room. I inject your hip with a cocktail of drugs that is very effective at minimizing the pain that you feel immediately after surgery. Now, nothing can relieve all pain except general anesthesia, and for obvious reasons we can't give you continuous general anesthesia. But we start with the local anesthetic injection, and then we have a protocol of medications that you receive after surgery. Some you'll receive whether you ask for them or not, just to give you a certain level of pain control. And then you'll have rescue medications that you can ask for if the pain is above what those medications are controlling. And that comes in the form both of pills and of IV injections.
We're doing a lot of different things for pain control, and this is evolving over time. We used to do things in the past to help with a patient's pain after surgery that we no longer do, and we're continually finding newer ways to help with the pain. Basically, what I tell patients is that the biggest benefit particularly after hip replacement surgery, is that most patients know in the recovery room that it's a different kind of pain. The surgery pain is manageable pain with medications or injections that we use, compared to that awful arthritic pain. So the postoperative pain is not that much of a problem. We have a lot of ways to manage that, which we can easily control with medications.